Welcome, everyone. Thank you so much for joining us today. My name is Louise Ivers. I am the faculty director here at the Harvard Global Health Institute. It's my pleasure to welcome you to HDHI's Global Health Research and Innovation Speaker Series. This monthly series is hosted by us and designed to showcase the latest advancements in global health research with the goal of fostering dialogue and elevating innovative solutions to advance health outcomes worldwide. We welcome you to continue to join us for more timely discussions every month. Before I introduce our speaker today, I have a few notes. The session is being recorded through Zoom, and the recording will be made available on the website and the HDHI YouTube page in the coming days. We will have time at the end for questions. So if you have a question for Professor Kanki, you can submit it through the Q&A feature on the bottom of your screen, and we'll do our best to get to those towards the end of the event. So with that, let me please introduce our speaker today. Professor Phyllis Kanki is the Mary Woodard Lasker Professor of Health Sciences at the Harvard T.H. Chan School of Public Health. She has worked in West Africa since 1984, where her research in Senegal provided the initial characterization of HIV-2, demonstrated reduced virulence, transmission, and progression to disease and interactions with HIV-1 subtypes. In 2000, she founded the AIDS Prevention Initiative in Nigeria, supported by the Bill and Melinda Gates Foundation, modeled after the Senegal research collaboration. She led Harvard's PEPFAR program, supporting prevention, care, and HIV treatment for over 200,000 patients in Nigeria, Botswana, and Tanzania from 2005 to 2013. In West Africa, following epidemics of Ebola and Zika virus, she documented the multi-decade presence of Zika, demonstrating the endemicity of this unique arbovirus in the region. She's just completed a 3-year study of Zika, dengue, and chikungunya virus infection in pregnant women. I'm really thrilled to have Professor Kanki here today. Look forward to hearing this talk, and I welcome you to take the stage. Thank you.
Great. Thank you very much, Louise. It's a pleasure to be here. And today I'm going to talk to you all about our recent study. There are actually ongoing studies of arbovirus infection in pregnancy that we're conducting in Nigeria. Okay, so let's get started. I guess one of the reasons that we began this study was that we were inspired by what happened in the Americas in 2014 with the Zika outbreak. And we knew that the Zika virus, which is a flavivirus, originally was described in West Africa. And so we really wondered whether these viruses like Zika and dengue were really causing problems in our populations in West Africa, and we weren't really recognizing it. So that's what inspired it. As many of you know, there are a number of viruses and other even bacteria, pathogens, and fungi that are carried by arthropod vectors, those being insects like mosquitoes, ticks, spiders even. But the most common that we think about typically in the world is mosquitoes and ticks, and flaviviruses and alphaviruses are a broad group of viruses with many close relatives that are distributed across the world, and you can see them in these different global maps where the endemicity of these viruses or even the spread of outbreaks are a result of where the mosquitoes really are. And we also see alpha viruses, and chikungunya is one example of an alpha virus. And again, that's in the middle panel with the green shading. And again, you see these viruses that are distributed because of the arbovirus vector, the mosquito in this case. And you see Venezuelan equine encephalitis virus. We're currently worried in Massachusetts about Eastern equine encephalitis virus, another related alpha virus. So all of these viruses are around. We worry about them in seasons or in areas where we have these mosquitoes. And the question that we really had for those of us who work in places like West Africa, where mosquitoes are prevalent throughout the year, is, what are these viruses carried by these mosquitoes doing in our different human populations? And so what I've shown over on the left is that although we know that there's recognized outbreaks of hemorrhagic disease, for instance, with dengue, or even sort of the orthopedic manifestations that you see with chikungunya, we wondered more about maternal health and the effect on pregnancy. We know that flaviviruses and alphaviruses are associated with fetal loss and premature birth. We know from the outbreak in the Americas that Zika virus was teratogenic, and we knew from the history of chikungunya outbreaks that there can be severe neonatal disease. So all of these three viruses are single-stranded RNA viruses. Zika and dengue are both flaviviruses. They're closely related. In fact, their close genetic relationship causes diagnostic challenges because they're very difficult to distinguish. And chikungunya, which is a different virus, all three of them have these nonspecific symptoms that patients present with. So it's flu-like symptoms, fever, rash, headache, malaise, and it's not something that's easy to distinguish. It's often confused with things like malaria or typhoid. So here's the phylogenetic tree, and here's the Asia-related viruses. And what occurred is that the viruses that were in East Africa actually changed, and there was a mutation that occurred that allowed these viruses now to be transmitted by a different mosquito vector, that being Aedes albopictus. And that had actually not been seen previously with other viral pathogens. So it's something that we're concerned about when we think about global pathogens and arboviruses in general. And now in Asia, when you have chikungunya outbreaks or back into the Americas, those lineages are now the Asia-related viruses, and those are all transmitted, have the ability to be transmitted by albopictus. So as most of you probably recognize, dengue is sort of a worldwide global public health pathogen, mainly in Asia, but also in the Americas. We don't hear about it too much in Africa, but some of that reporting is coming in more recent times. And we have seen a few outbreaks, primarily in West Africa, with all of the different dengue types. There are 4, and Senegal, Burkina Faso, and Ivory Coast have reported severe outbreaks, but not large numbers, not like what we see in Asia or in the Americas. And then all of you are familiar with Zika, first described basically in the 50s in Nigeria and Uganda. It then appeared to move to Micronesia, and there were outbreaks in Yap Island in 2007. And then in 2014, we had the massive outbreak in Brazil that resulted in over 1.5 million infections. And the really unusual characteristic of the microcephaly. And it was later described, recognized that in adults, you can see a neurologic syndrome called Guillain-Barré syndrome, which had also been seen in the Micronesia outbreaks. So we wanted to know what happened with Zika in Africa. Was it still around? And my former student, Bobby Brooke Herrera, did serologic surveys in West Africa going back 25 years and showing that Zika was in fact still circulating during that time with IgM positive, antibody positive individuals seen in Senegal and Nigeria. And these are the sequence analysis of some of those positive individuals. And you can see that they really are coming from the African lineage of Zika virus as opposed to the Asian lineage. And there's some thought that the Asian lineage because of the genetic mutations that are noted in that virus strain, that may be associated with the microcephaly, although in animal models, the African strains do cause microcephaly in both rodents and in primates. So it's still a little bit unclear, and that's was some of the impetus for us to conduct this study. Just so that we can review, these viral infections are very similar to things like flu or SARS-CoV-2, where you have a relatively short viremia with symptoms, maybe 7 to 10 days, and then the mounting of an antibody response. Both the IgM, which is usually diagnostic for the acute infection, and then the IgG, which is usually later and what we consider the convalescent. Now, with flaviviruses like Zika and dengue, we don't rely just on antibodies. We would like to see a plaque reduction neutralization assay or evidence of nucleic acid in the PCR, which is often more difficult to capture depending on whether we've gotten a sample at the critical time when the nucleic acid is peaking here in the viremic stage. So one of the reasons we wanted to study Zika virus was, as I said, because of the outbreak. And we wondered whether we, recognizing that there was circulating Zika virus, was there no microcephaly because it was a different strain, or was it because of underreporting? And then we also recognized that there were other flaviviruses that were infecting our populations, and could those flavivirus infections provide immunologic protection? So this is the study design that we developed. We were screening pregnant women on their first antenatal visit, and we were using a rapid test so that we could identify right at the time of their first visit whether they were antibody positive, either IgM or IgG. So the acute infected would be the IgM positives for either Zika, dengue, and chikungunya. And if they were acutely infected, then we would enroll them in a prospective study, and we would collect additional blood samples from those women, and then collect samples from their babies, and then follow their babies to determine if we saw any abnormalities like the microcephaly. And this is at one of our participating hospitals, Jos University Teaching Hospital. It's in the north central area of Nigeria. And this is a fact sheet that was distributed in the waiting room for the pregnant women. We have about 100 women coming in for visits every day. And we started the study in 2018, but actually ran the study even during the COVID pandemic. Although pregnant women still were coming in, they often had shorter hours in the antenatal clinic because of COVID. So this is our lab team in there, and this is an example of our rapid test. It's a nice rapid test that tests for all three viruses, and it also tests for both IgM and IgG. So you can see the bands up here and down here, and it gives you a result in about 15 minutes. So it's not a perfect assay, but it was a great assay for us to use to identify women who were positive that we wanted to enroll in our prospective study. And this is a result of our IgM and IgG data collected over 3 rainy seasons, which are shown here with the little clouds and the raindrops. And you can see we had, during those periods, we had a larger number of women who were symptomatic, who were willing to be screened. And we had higher rates of the most prevalent arbovirus was chikungunya, which is shown in red, followed by dengue, and Zika was lower level, but we still saw persistent, all three of these viruses, and these are all IgM. So these are acutely infected women, and these are women who would be at risk for developing microcephaly in the babies. And this is the diagnostic algorithm. As I indicated, antibody diagnosis is difficult with flaviviruses because they're so closely related. And we had a great collaborator, Professor Wei-Kung Wang, who's at the University of Hawaii, who developed many of these assays. So he has virus-like particle ELISAs that are more specific for dengue and Zika. And we used those. And then for chikungunya, we used envelope-centered ELISA, and then we used the NS1 as a secondary antigen to discriminate it, and then went to neutralization. So this is a sort of final diagnostic that you need to do with some of these flaviviruses. And this is showing an example of a multi-typic infection. So this is a woman who had both Zika and dengue 2 infection and dengue 4. Here's dengue 1, here's Zika alone, and Zika alone. And you can see that we're starting to collect the pregnancy outcomes for our women. And Wei-Kung was also able to develop a microneutralization assay for chikungunya. We have to compare it to the closely related Arbovirus, which is more often seen in Asia. But in this instance, he's developed a mosaic virus that has the envelope of chick, and he's going in and asking whether or not sera will block the envelope of chikungunya in a neutralization assay directed at susceptible cells. And he's using a reporter here, which is the cherry red, so he can do a nice readout with diluted samples. So here are examples of samples that were positive for chikungunya neutralization, not myaro. These are Brazilian controls, so that you can see that he's developed the specificity of the assay for chick. So in the end, we ended up having about 180 women out of 1,000 that were screened over the 34 months. We had significant co-infection of arboviruses, chick and dengue, chick and Zika, Zika and dengue, all three combinations. And this kind of co-infection had not really been reported very often, because most serosurveys that are in the literature frequently only look for one infection, like dengue or Zika alone, and they don't look at these together. So that was an advantage that we had. We know that these areas are endemic for the same mosquito vector, so we know that they're at risk. And we know from mosquito studies that a mosquito is capable of carrying more than one arbovirus in their saliva. And there have been a few reports where people have have reported whether or not mosquitoes are competent for transmission. and there are certainly, at least from Asia, a few cases of multiple infections. Another thing that we thought was interesting about our study was we had also screened women who were asymptomatic. Most of our women were symptomatic. There was about a 4-to-1 ratio of symptomatic to asymptomatic, but we did sample about 200 women who had no symptoms. And what you see here is, at least by rapid test, significantly high rates of all of these viruses in women without symptoms. And this had been seen in outbreaks in Asia and in the Americas, but had not been appreciated well in Africa at all. So basically, we're seeing almost a 2-to-1 ratio. So women who are not symptomatic are almost twice as likely to be positive. And that's something for us to think about in our future studies of these viruses and in future interventions. And then the most important thing was for us to look at pregnancy outcomes. And this just gives you a flavor about how we were doing this. By then, we had already made definitive serodiagnostics on these women, early Zika, and early chikungunya, and we had pregnancy outcomes listed here. And here's just an example of a nucleic acid detection using subgenomic for Zika, the NS4 gene. We were able to describe it in at least some of our women, but not all. And this is sort of the final study. It's not definitive, but we were able to look at the birth outcomes in our 2 hospitals over the 2-year period. So that was close to 6,000 births. And so this is our control group. And in those 6,000 births, we had about 9% gross abnormalities at delivery. And now we compare that to women, infants that were born to women with acute arbovirus infection, either Zika, dengue, or chikungunya, or some combination. And you see that there's a much higher rate of abnormal outcomes, and the ones that are statistically significant are shown in red. And then here are ones that are more confirmed. So this is like a sensitivity analysis. If you wanted to say, I only want to look at people who have neutralization data to confirm that they're arbovirus infection, we still see a significant difference. So we're not able to have sufficient numbers of each of these viruses alone to determine which one is associated, but we do see that acute arbovirus infection is associated with the birth abnormality. So overall, we've seen low levels of acute infection and also significant co-infection. Almost a quarter of our women were infected with more than one arbovirus. Our asymptomatic or women were even more likely to be infected with an arbovirus. We didn't see, and I didn't show this data, evidence of pre-existing immunity to arboviruses, and that was the IgG data. It was basically low, and so we do not argue that other arboviruses or immunity to other arboviruses is protecting us from either hemorrhagic dengue or severe chikungunya, or even abnormal microcephaly. But we did see the abnormality of birth outcomes associated with acute arbovirus infection. So these studies have been published. So if you want more information, you can go to them. And I'd like to acknowledge funders, this was a R21 and R01 funded study, University of Hawaii, the Jos University Teaching Hospital, and Our Lady of Apostles in Jos, and our collaborators there. This is Wei Kung Wang. And then in this last year, we've received a small grant to do further studies of our birth abnormalities from the Center for African Studies. So we hope to have more information about which viruses we think may be associated with these abnormalities and what characterize the birth abnormalities a little bit more. So with that, I'll end.
Thank you so much. I have a lot of questions, and I know we have some coming in from the audience. Please do go ahead and submit a question if you have one. I wanted to start with a question for you about how you're seeing the broader public health implications of your study. I know as well, because of your experience running large PEPFAR programs and responding to the HIV pandemic, every time we look for things that we just haven't tested for, we're often finding them, and then we somehow get surprised about outbreaks. How do you think, from a public health perspective, this type of finding could be responded to if there's a much higher prevalence of important arboviruses and pathogens in populations? What could we be doing, or should we be doing more?
Well, you get into the difficult question about what can we do with arthropod vectors, and that's not something that I had to deal with much in my career. I mean, clearly, when I was working on HIV, we were concerned with things like TB or with malaria, and even in the PEPFAR program, we did distribute bed nets and talk about standing water and the risks to that. The malaria programs have made tremendous progress, and there are vaccines out there. And I expect that's going to carry over to some of these arbovirus infections as well. We will not only sort of work on the side of the environment and think about mosquito protection or insect protection, et cetera. How do we protect populations? But also vaccines. And we know from our experience with COVID that it is possible to get an effective vaccine quickly. And I hope that will carry over to populations so that they'll have more trust in vaccines as they roll out for any of these new pathogens that come down the road. Because I think that's probably one of the most effective and cost-efficient ways of preventing some of these diseases.
Yeah, thanks. Actually, two of our audience members have asked about vaccines. One is a question about a chikungunya single-dose live attenuated vaccine that was approved last fall. Curious about your knowledge of it, thoughts about it. And then another question asking about dengue vaccine, recently introduced to Africa, and whether you think how that will go.
There's a lot. I think there's a lot of interest in the research community about what's going to happen in places like Africa with the new dengue vaccines that are coming out. It's an instance where Asia and Latin America are way ahead of us in sort of understanding the biology of dengue and Zika and related flaviviruses. Asia has Japanese encephalitis virus. So our hospitals, our clinical folks, and our laboratories in Africa are really not well equipped to think about this. And the amount of research that's been done has been really sparse. So we need to sort of step up to the plate and get more information about what's the underlying level of flavivirus infection, and understand that as these new vaccines come out, because we are concerned, particularly with things like dengue vaccines, if pre-existing immunity is going to impact adversely the efficacy of these vaccines. On the question of chikungunya, unfortunately, I just don't know enough about that vaccine trial and what's going on with it. I think one of the issues, again, it's the same story as with flaviviruses, that there have been few outbreaks of chikungunya, and it's just not, there's not regular surveillance for it. Um, that's and there's a little bit of that carries over to the US. I mean, um, I think there's certainly cases with travelers, and maybe cases down in Florida because of the vector. But we're sort of sitting ducks waiting for some of these things to happen. And then when it occurs, then we'll have to put in place surveillance mechanisms. But for a place like Africa, the real question is, how do you prioritize which pathogens you need to survey for to begin with?
Yeah, thanks. And you described in your talk the issues around testing for these three viruses and how antibody testing can be not specific enough to really help distinguish, and the additional steps you went through to be more specific. How do you think this plays into regional laboratories and the need for surveillance? Because are there technical reasons why we can't make better tests that could be used more adeptly for surveillance? Why, couldn't we make it more widely available, or is that possible and it just hasn't been prioritized? Could you speak a little bit more to that? Because you did dive into the plaque neutralization and the antibodies and the efforts you went to be specific, but could that be used in public health? Is it expensive?
I think the costs of all of these are coming down, and that's largely because of the importance in Asia and Latin America. And so the tech, the tech companies have responded with assays, cheaper rapid tests, multiplexed RT-PCR assays. Um, and I would say that overall, our experience with some of these things, like even COVID, you have more, you know, laboratories in all settings, including Africa, that are capable of doing RT-PCR assays. So the tests are not horribly expensive. And they're coming down. And then using multiplex, I think that really helps. And I think we are moving into that arena. And as long as from the public health standpoint, we consider that surveillance is the most important thing that we can put in place, um, you know, relatively at low cost, because the cost of responding to an outbreak is so much more than what it would cost you to do to have regular surveillance. I mean, even simple things, if you're concerned about maternal health, implementing better systems, health systems for recording birth abnormalities and pregnancy outcomes, that's really important. And that's not something that we've done uniformly across the African continent, and something that would really benefit the populations, I think.
Yeah, thanks. Two questions that I'm going to combine together are asking a bit more specifically about your study outcomes. Did you find any particular clinical markers or any laboratory markers that helped you understand which of the women developed the abnormalities more than others and in their pregnancy outcomes? And then a question from Kenya about which other factors you looked at in terms of controlling for outcome, for example, gestation period or malaria, placental malaria, etc. We asked you to be brief in your comments, so you didn't have time to dive into all the details, but folks are interested in more information on that.
Yeah, we didn't have very detailed data on malaria, as you can um, gather. And we did have questionnaire data about mosquito exposure, and certainly we had two different hospitals that were feeding into our study, and one was they were both in Jos in Plateau State. Um, but the study populations are slightly different. And at Our Lady of Apostle, it's a slightly poorer socioeconomic group, and there's a different ethnic demographic mix as well. And we had much higher rates of arbovirus infection and by questionnaire, much more exposure to mosquitoes. Either occupationally or in the home. So even within, one city, we were seeing sort of massive differences. Um, and it was something for us to think about. And it's also we've moved forward with the hospital to try to figure out ways that we can talk to pregnant women when they come into antenatal visits to protect themselves and to do more about using bed nets and standing water risks, etc.
Yeah, I noticed, we experienced this when I worked in Haiti during the Zika epidemic, and, advising people to take interventions that they are materially unable to do because of their work taking them outside, or their assets and their ability to have long sleeved clothing on when it's really, really hot outside can be very challenging. And so it's not surprising to hear you explain those differences based on exposure. Um, how do you mentioned the environment, and it's on our mind a lot about how climate change is impacting the vectors of many of these viruses. How do you think about this, how this all fits in together, whether it's in your research or your public health experience about how we're addressing climate change and particularly mosquito-borne illnesses?
Yeah, I think it's a big question mark about what's going to happen with the distribution of these arthropod vectors with climate change. Um, there, I've heard some discussions from the malaria community that they feel that the risks for malaria will change and might even diminish with increased climate because of drought. So, and um, if that is true, you might think that that would also happen um, with arbovirus risk as well. I mean, it's the same mosquito, right? But you'll also see probably adaptation of the mosquitoes to the climate change. And so I think our current study that we're beginning now and new studies are being really rigorous in documenting, climate, humidity, land use in and around the regions that we're talking about, because we recognize that these are going to be the parameters that are so important in the future because of the change that is occurring now and is anticipated.
Right, a lot that we don't know yet. So we're coming close to the end of our time already. It's hard to believe. It goes by quickly. Um, can I ask you for any closing thoughts or any closing comments? Did you get to say everything you had hoped to say?
Well, I will say that I do think that arboviruses are not the easiest viruses from a virology point of view. They're not the easiest viruses to study, but they're really important. And I've had a real new appreciation of uh, the how important I think it is for for those folks that study the vectors, um, and also for what goes on in places like Asia and Latin America, where I haven't worked as much, but there's wonderful models to arbovirus surveillance, interventions, vaccine development. And I hope that, we can work in a more global way about keeping those lessons sort of flowing across over to Africa, which is where I work most of the time, because these pathogens are affecting all of us. Um, and I think that would be a wonderful outcome to some of this work. So
Well, thank you tremendously. Really appreciated this lecture and your insights. I learned a lot. Thanks so much to our audience for joining, for your participation, asking questions. Our session today has been recorded, as we said, and it'll be available online at the Harvard Global Health Institute website in the coming days. Thank you, Professor Kanki. Thanks to all of our participants. I hope everyone has a good day. Thank you.
thanks.